So welcome, Diane. Welcome, visitors. This is our Lunch with an Expert talk. And for everybody who's joining us, we will be recording, but it'll only be the speaker and the slides. And those will be available on our website in about a week under the blog if you want to share it with others. We will have a talk for a little while, and then at the end we'll take questions in the chat box, preferably. If you're not able to type into the chat box, you can turn on your audio to ask a question, and we do encourage that, so we will save time at the end. So Diane Dempcy is with us today. She's a psychotherapist in private practice in Seattle, and she specializes in anxiety, depression, and trauma for adults. She has a master's degree in clinical mental health counseling from Naropa University, and she utilizes both Eastern and Western approaches to healing. And she's trained as an EMDR therapist. We will put, I think her contact information will be up on her slides so that you can write it down, and I will type it into the chat box as well. Thanks for joining us, Diane. Let's get started.
Great. Well, thank you, Dr. Moore, for the invitation to talk about anxiety. As you said, I think anxiety is ubiquitous in this time. And I'm finding that there is so much to talk about anxiety. We don't have a lot of time together, so I'm going to briefly touch on a number of aspects so that you can hopefully recognize maybe some anxiety or anxiety disorders within yourself, and then provide you some tips on how to reduce your anxiety, and then maybe when to find professional help. So I think I just went over the agenda. Okay, good. So types of anxiety, we're going to be talking about the physiology of anxiety, reducing anxiety activation, and then again, when to seek professional help. There are a number of anxiety disorders, but I'm just going to highlight some of the more common anxiety disorders. So the first one is generalized anxiety disorder. This is probably the most common one I see in my practice. And I call it GAD. So GAD is characterized by this constant state of worry or fear that interferes with daily life. I like to think of GAD as we're stuck on the worry channel. We worry about things like work, money, family, friends, health. And we experience, physiologically, we experience this sense of restlessness or feeling on edge. Perhaps we get easily fatigued, our appetite decreases, we have difficulty concentrating, we might be irritable. We experience sleep disturbances and perhaps muscle tension. To be diagnosed with GAD, you need to have anxiety for more days than not. More days than not for 6 months. And then we have social anxiety disorder, and I'm going to call SAD for the purpose of this presentation. SAD is characterized by a strong and persistent fear of being judged by others, such as when meeting unfamiliar people or having conversations, perhaps being observed, or if there's a performance in front of others, such as a job interview or a presentation even. And many of us have this to some degree, but when we start avoiding situations or we endure these situations with intense fear, then it might be social anxiety disorder. Panic disorder is characterized by repeated panic attacks. And the physical symptoms of a panic attack are our heart palpitations, shortness of breath, dizziness, trembling. And then we have these thoughts of fear of dying, I'm going crazy, or I'm losing control. But to qualify for a panic disorder, you need to have 2 or more panic attacks, and at least one of these panic attacks has been followed by 1 month or more of concern about having another panic attack. OCD, or obsessive compulsive disorder, are intrusive thoughts that then trigger compulsive behaviors. So these behaviors are such things as excessive checking, excessive counting, excessive ordering or cleaning. These are just some examples. And the the compulsions are really performed in order to alleviate the obsessive thoughts. And the obsessive thoughts can be these recurring ideas, thoughts, images, or impulses that seem senseless, and maybe even sometimes these thoughts seem disturbing, but nonetheless intrude, and we can't seem to stop them. You can have obsessive thoughts without the compulsion to qualify for OCD. PTSD, post-traumatic stress disorder, develops in response to a shocking, frightening, or traumatic event, or witnessing or hearing about a frightening, traumatic, or shocking event. The symptoms of PTSD are nightmares, flashbacks, problems with concentration, hypervigilance. And to be diagnosed with PTSD, it is characterized by a single event. So you could be exposed to military, something going on in military combat. There could be a sexual assault, a natural disaster, or a motor vehicle accident. And then there's complex post-traumatic stress disorder. And I have this in parentheses because it is not listed in our diagnostic manual for mental health disorders. People have tried to get it in there and lobbied to get in there, but it hasn't happened yet. But I think they're going to keep persisting. So complex trauma is characterized by repeated traumas or disturbing events, usually happening in childhood. So these can be such things as neglect in childhood, different forms of abuse, witnessing domestic violence, our caretakers having a substance abuse disorder, or perhaps other mental health disorders. Okay. And then I just want to say a word about normal anxiety. We all have normal anxiety. I think I can, yeah, get my screen. There we go. We all have normal anxiety. We all have kind of this optimal state of arousal. This is just part of our basic operating system, and we really want it there. Normal anxiety tells us that there's something to be paid attention to. It keeps us sharp. It keeps us motivated. It gives us energy and focus. So anxiety is really good when I'm on the freeway in rush hour traffic. Normal anxiety, this optimal arousal, is really good as I'm preparing for a presentation, or maybe somebody's studying for a test. But the issue is when we start getting, the anxiety starts getting too high, and it really starts impairing our performance, or the anxiety, or we don't really have enough of that to kind of get us motivated to do things. Okay. There are a number of ways to talk about anxiety. I am going to talk about it from a physiological perspective. Specifically, I want to talk about the neurobiology of anxiety, because if I can understand how the brain triggers anxiety, then I can start rewiring my brain to respond differently to anxiety, to events or memories that may come up. So let's dive into that. Okay, so there are two pathways to anxiety. One is through the prefrontal cortex, and the other is straight to the amygdala. So the other is straight to the amygdala. And the amygdala is the place that actually triggers the anxiety. So the cortex is our executive functioning. It helps us concentrate. It gives us reason, logic, decision-making, planning. It's where I kind of conduct my day from, if all is well. So the cortex can initiate anxiety, but it can't create anxiety. I'll say that again. The cortex can initiate anxiety, but it can't create anxiety. So the way that the cortex initiates anxiety is through thoughts in the form of interpretations, cognitive distortions, mistaken beliefs. Perhaps we're ruminating about the past or worried about the future. Perhaps we're making mistaken assumptions, or we're playing out worst case scenarios. So let's give an example of this. I don't think I can, yeah, I can't do my animation through here, so we'll just go with as it is. Okay, so let's just say I've got an event. And the event in an objective, reportable way is I emailed him 30 minutes ago and I haven't heard back. And I may have a sensation. I may recognize a sensation or it's happening below conscious level, but nonetheless, I might register this knot in my stomach or this kind of spreading of warmth or tension in my chest. And then my brain wants to pick up, my cortex wants to pick up that sensation and interpret that or make an interpretation of he thinks I'm a creep and I've got this underlying sense of rejection. So that thought triggers the cortex, which activates the amygdala, which provokes the anxiety response. So what would happen if I just kind of stopped here? What if I just had this reportable objective event and I just had the sensation and I just stayed with the sensation without going into the cortex and making an interpretation? If I stay with the sensation, notice the knot in my stomach, notice the tension in my chest, breathe into it, it usually dissipates and goes away so that I can just be with the reportable event. And then the other way is through the amygdala, and that's straight to the anxiety response. The amygdala is responsible for such things as love and bonding, sexual behavior, anger, aggression, agitation, and kind of in a general sense, the amygdala is responsible for attaching emotional significance to events. So I'm going to give you a hypothetical situation. Say I've got a client and she comes to me and says, my son really wants a dog, and I think it would be great to have a dog in the family. I think it would really do a lot for us, but I can't get myself to look for a dog. I'm lazy. I am procrastinating. I don't know what's going on. And I say, well, first of all, I don't believe in laziness. Laziness is a judgment. And if you are procrastinating, let's see what's there. Let's do some investigative work. So as we're talking, she realizes that she's had this memory of being bitten by a dog when she was 5 years old. And the bite was a little severe. It hurt, it caused pain, and it caused a lot of fear. And then parents took her to a hospital where she got a shot, and she hates shots. So she's got this incident, this event of being bitten by a dog and getting a shot. She comes back home and I said, well, when you came back home, did your parents or did other people kind of help you through this? And she said, no, it just kind of went to bed. And the next day, I was still scared, but we just kind of went on with our lives and we've never had dogs. And I said, I bet that your amygdala, your brain, paired the pain and the fear with the dog. So as you're going through your life, you may be avoiding dogs or you may not register dogs, but when it's more kind of front and center in your life, you're having this reaction below conscious level. Your amygdala is triggered and the amygdala wants to avoid. So this fear or this anger triggers the fight, flight, freeze response in the amygdala, which is part of the nervous system. So we're going to discuss that. So there are two parts to the nervous system. There's the sympathetic and the parasympathetic nervous system. These are also part of our operating system. We want these. They're very helpfthe for us in many situations. So the sympathetic nervous system is the accelerator. It's the fight, flight, freeze response. And when the amygdala triggers the fight, flight, freeze response, our body prepares for stress. It releases cortisol and adrenaline. Our heart rate and our blood pressure increase. The blood flow moves from our digestion and internal organs into our major muscle groups so that we can get ready to fight, flight, or freeze. So once the threat has passed, our parasympathetic nervous system kicks in. This is the break. This is the rest and digest. Here, the body returns to normal. We're releasing calming hormones, the heart rate and blood pressure decrease. The body starts repairing by maybe sopping up that extra cortisol and adrenaline. So The issue here is when the sympathetic nervous system is constantly accelerated. It's constantly on. This could happen starting in childhood. If there was abuse, neglect, maybe that bullying, we never felt safe at home, the sympathetic nervous system can be aroused constantly. Another example could be we take a really stressful, high pressure job, and we're in that job for perhaps years. And our sympathetic nervous system is on. Our amygdala registers that job as kind of a threat. So it's just constantly on. So this is kind of the nervous system activation. So if we're already accelerated 30 miles an hour, maybe 50 or 60 miles an hour, and then something else in our environment comes up that might be unsafe or threatening, then our anxiety really hits the roof. So the first thing that I do with clients is help them recognize when they have that sympathetic arousal. And I like to explain this through what we call the window of tolerance. So in this mid panel is this kind of baseline place where we're in this rest and digest place. We feel grounded, we're flexible, we feel present, we're able to emotionally regulate. So as I go through my day, maybe something happens that kind of activates my nervous system. Maybe it's a piece of bad news, or something happens and I kind of feel sad, but I'm kind of going in and out. I'm modulating through my window of tolerance. I may get higher, I may get lower, but I also have skills to come back into that baseline if I'm activated. So if we do get that sympathetic activation, we can either go to hyperarousal or hypoarousal. And hyperarousal is that kind of that nervous, agitated, sweaty palm place where we have that high energy. We may feel overwhelmed and we may feel hypervigilant and we're in that kind of fight or flight place. Or we can go to hypoarousal. Maybe we shut down, we get depressed and numb, maybe we freeze and maybe there's some dissociative tendencies. But we can either kind of be slightly outside our window of tolerance, hypo or hyperaroused, or like really outside our window of tolerance. So I just want to invite you, as I'm describing the window of tolerance and these different states of arousal to you, where's your go-to? Where do you tend to go? Do you tend to go to hyperarousal or hypoarousal? I know for me that my tendency was to go to kind of hypoarousal. I kind of go to a little bit of a shutdown place. And honestly, since COVID, that's really changed. I tend to go to hyperarousal. I tend to kind of be a little more hyped up these days. Okay, so then the thing is, once we recognize that we're outside our window of tolerance, that our sympathetic nervous system is activated, how do we regulate the amygdala? And there's different ways to regulate it. One is through the prefrontal cortex and one is through the amygdala. So we talked a little bit about maybe how to stop the prefrontal cortex from making interpretations by just staying with the sensations. But there's a couple of other ways. The first one listed here is to embrace uncertainty. This is a tall order, I realize. The brain really likes security. It really likes certainty. It likes to know where its next meal is coming from. It likes to know where it's going to rest its head at night. We really like uncertainty. However, life is uncertain and is becoming increasingly uncertain. So we can rewire or we can train our brain to embrace uncertainty. Some suggestions could be through spirituality, or there might be some religious doctrine that you know about that could be of comfort and could inform you how to embrace uncertainty. Perhaps there's philosophical ideas that might help. Buddhism is really good for kind of talking about the impermanence of things. We also want to stop avoiding, we want to avoid avoiding. So anxiety is really uncomfortable. And what we wanted and our tendency is to avoid the things that cause anxiety. And when we avoid we avoid the things that cause anxiety, we feel a sense of relief. I can just feel it right now. I feel a sense of relief. And then we get conditioned to want that sense of relief. But that sense of relief actually keeps us in that anxiety state. So we want to actually move towards doing things that cause anxiety, because then it teaches the amygdala that, like, I can do this and I'm safe and I made it through. And if we do that over and over and over again, we're teaching our anxiety that we're okay, that we can do this, that nothing bad's going to happen. And then the next one is to change self-talk and mistaken beliefs. These self-talk and these mistaken beliefs originate in the cortex. So I'll give you an example of how that looks. So say I've got this thought that I'm a burden. It could have originated in childhood. I could have had this thought all my life, and there's no differentiation between the thought and who I am. I am a burden. And this activates the amygdala. So what I encourage people to do is to start separating the thought from who they are. So I can put in this thought of, like, I'm having the thought that I'm a burden. And in that way, I start disconnecting the thought from who I am. And I can start being kind of curious and investigative about that thought. And then that way we start rewiring the brain as well. Then we can go to, I'm just okay the way I am. Just this sense, like, I'm all right. I'm not a burden. But sometimes going from this I'm a burden to I'm just okay the way I am can be a really big leap, and it can be discouraging. So I love for people to go to this, having the thought, to start giving some space to this kind of chronic self-talk. And then there's amygdala-based skills. The first one, my go-to always, is diaphragmatic breathing. People with anxiety tend to breathe from their chest, and they tend to breathe shallowly. And this signals, when we do this, this signals the sympathetic nervous system to get ready to fight, flight, or freeze. So in order to engage the parasympathetic nervous system, we start breathing through our bellies, and like breathing to expand, like with kind of that sense of our rib cage, and like sometimes breathing so our back kind of expands. We want to get into that kind of deeper belly breathing. And then the next one is connecting to our sensations. And I love doing this through something called 5, 4, 3, 2, 1. So I could say, find 5 red things in your room right now. And you've got to go looking. If you have a lot of red, you might pick blue. So you've really got to use your visual senses to find those blue things. Touch 4 things. Find 3 sounds. Smell 2 things. And then taste what's in your mouth right now. And again, in this way, I'm bringing myself to the present moment through my senses. I'm kind of cutting off the thought process. And then the last one is temperature. Coldness seems to stimulate neurotransmitters. And so a couple of ways to do that are putting oranges in your freezer. And when you start getting outside your window of tolerance, grab an orange and maybe put it in your palm, and then smell it. Engaging the smell sense can be really powerful. Maybe I grab a bowl of ice cubes and just put my hands in them. If I grab an ice pack and I put it right here, like from my occipital bones up to my brow ridge, and I bend over, it stimulates something called the dive response, which again releases neurotransmitters. And if I'm out and about and none of these things are available, I can go into a bathroom, splash cold water on my face, or maybe run some cold water on my wrists. So again, these are ways to deactivate the sympathetic nervous system so that I can come back into my window of tolerance and start living from that parasympathetic place of rest and digest, and that place of like all is well. And then when to look for professional treatment. If you kind of got a sense, maybe as I was going through the anxiety disorders, that some of that sounded familiar to you and you wanted to get more information, it's a good time to consult with a mental health practitioner. If you're just like sick and tired of your anxiety and it's really impeding your life, that might be a good time to find a mental health practitioner. And there's a lot of interventions to help with anxiety. The good news is that we know a lot about anxiety now, and there's a lot of good treatments out there. I'm going to highlight three, excuse me. One is cognitive behavioral therapy, and that is psychoeducation. I've been giving you a lot of psychoeducation to date, like what is the nature of anxiety? How does it work? What can we do about it? Cognitive restructuring. If I change the way I think, I can change the way I feel, and I can change the way I behave. And then exposure is that avoiding. A therapist that has been trained in exposure therapy can help you start taking baby steps to engage in things that cause anxiety, so your amygdala won't get activated. Dialectical behavioral therapy, or DBT, is a skills-based therapy. It teaches interpersonal skills, mindfulness skills, emotional regulation skills, and distress tolerance skills. And a lot of the skills that I was talking to you about today are DBT skills, how to decrease your distress. And then EMDR, as Dr. Moore mentioned, I'm an EMDR trained therapist. And I want to say a couple of words about it because I think people have heard about it, but they don't really know what it is. EMDR stands for Eye Movement Desensitization Reprocessing. It's recommended by many of the most well-known organizations nationally and some globally. EMDR is highly researched, evidence-based therapy. The research, they've got 40 years of research treating PTSD, and there's becoming more research in the treatment and using EMDR in the treatment of anxiety, depression, and addiction. And the way that it works is integrating the right and the left hemisphere. I'm just going to give you like a thumbnail sketch of how it works. Integrating the right and the left hemisphere in order to release the charge around memories, release the charge around trauma or disturbing events, so that I can have the memory without the anxiety, without the trauma, without the charge. And it does that through something called bilateral stimulation. So we do a right, left, and it can be the eyes moving eyes, right, left, or it can be tapping right, left. We don't quite know why the bilateral stimulation releases the charge, but it works. I use EMDR all the time in my practice, and I see people reduce their anxiety, move through traumas that have been with them for many, many years. So it's a particular favorite of mine. I hope that this kind of general quick information has been helpful, and I'm happy to take any questions that you may have.
Well, until we stir some questions, that was wonderful. Thank you so much. It was a fantastic overview of interventions as well. I think one of the things people ask a lot is if they can improve anxiety without going into deeper memories. So are you able to improve anxiety without talking about childhood and those kinds of things?
Yeah, great question. Yes, because we can treat anxiety by like working with the amygdala, by really deactivating the amygdala without going into those kind of deeper childhood memories. it's not necessary. Yeah.
And then something that comes up as well is, especially with people who are just initially getting care for anxiety, is they want to know how long they're going to need treatment for. How would you prepare somebody for knowing how long it'll be?
Oh, that's such a hard question.
I know.
That's $1 million question. Dr. Moore, I don't have a good answer to that question. I would say if there's a like with general anxiety disorder, it probably won't take as long. I think with generalized anxiety disorder, a lot of these distress regulation skills that I talked about can be really helpful. PTSD, OCD can take a little bit longer. And I think even with anxiety disorders, there can be some kind of quicker work there where it would be more months than perhaps hard to say, probably more in the maybe 6-month, 8-month, 9-month time frame.
Perfect. We have a question about whether you see people with eating disorders or avoidant restrictive feeding intake disorders.
I don't specialize in that. I have some clients that have disordered eating and they work with someone, but I don't have that expertise. I don't have that training.
Okay. And if they have specific phobias that are fairly narrowly defined, that are not as broad as a full eating disorder, maybe just disordered eating, is that something you could work with?
Yeah.
Okay.
Yeah, definitely.
And oh gosh, and then I had another question that just left me. Another common question is, are there medications that interfere with EMDR being effective?
Yeah. Okay. Yes. EMDR works with a lot of medication, and it doesn't work well with the benzodiazepines. So if somebody is utilizing benzos, we can work with that, but it's suggested that they not use that medication, hopefully 24 hours before an EMDR session.
Okay. And so those are things like clonazepam, lorazepam, Xanax.
Yeah.
Okay.
Yeah, exactly.
And then how about cannabis products? Does it have a problem with EMDR?
It's best not to use any kind of substances. Medication is fine. Any kind of substances, we recommend 24 hours, but the minimum would be 12 hours.
Mhm.
So you don't have to be, you don't have to not use in order to engage in EMDR.
Perfect. And then we had a question about whether if somebody has impending retinal detachment, so it's been found by an ophthalmologist, is that safe with EMDR?
Yes, let me address that in a couple of different ways. So eye movement, what I do with folks when we get prepared for EMDR is just to check out, how are your eyes doing with the eye movement? Somebody with kind of that retinal problem, we would probably do tapping. Mm-hmm. Also, folks with traumatic brain injury, I would want to talk to your physician to get cleared with that. Some people with a kind of a minor TBI can do the eye movement, but also the tapping works really, really well. So there's all different kinds of ways to do the EMDR without the eye movement.
That's so helpful. Thank you. Let me see. I thought I saw a question, but it didn't. It's not there. Other questions that commonly come up are around specific phobias and if somebody has, we often see people with needle phobias, or, to go back to the example with eating, a phobia of vomiting, or those kinds of things. What's your experience with the best approach for patients to take?
I think the recommendation for that is exposure therapy. With vomiting, it would be exposure therapy. Finding some ways to kind of engage, not vomit necessarily, but I haven't worked with that one, so I don't know how that would work. But with phobias, it is about exposure therapy.
Mhm. Okay, very helpful. And then we had a question about finding a counselor in this environment, and particularly with a Medicare patient.
Oh boy, yeah. That's tough. Community mental health with the government insurance. This is something that my colleagues and I talk about all the time. Community mental health can be helpful.
And so in Seattle, that's Sound Mental Health.
Yeah, Sound Mental Health. You can also go on Psychology Today, and I think that they have a filter where you can put in the different kinds of insurance that you have, and then that'll bring out and that'll filter out the practitioners that take that insurance. So psychologytoday.com. There's another one that's really popular called Therapy Den, Therapy DEN. That also where a lot of therapist lists as well.
Okay. And I will I'll type these into the chat boxes so people can look them up. So Therapy Den. And then are you taking new patients?
I am taking new patients. Yeah.
And you are like us, a cash-based practice, so no insurance, is that correct?
That's right. I am out of network with Premera and Aetna, and I utilize telehealth at this time.
Okay.
And FYI, EMDR works really well with telehealth as well.
That's so great. There's such misconception about that right now. And so patients have heard about it. Another question I had, if people are interested, maybe they don't feel like it's bad enough that they need therapy, but they're interested in getting better. Do you have suggestions on reading they could do?
Oh, yeah, good question. I don't know. God, there's a lot of them. There's a workbook.
Anxiety and phobia?
Yeah, anxiety and phobia workbook that's really good. There's one called Rewiring the Anxious Brain. I think that's just kind of a smaller volume, smaller book. Those are the two I would probably recommend.
Those are great. And I would throw in there for patients who are afraid of opening the can of trauma. There's a book called The Body Keeps the Score. And I think it really can help framing getting better in a more positive way than I think it can be really scary to approach recovering from trauma sometimes.
Yeah, yeah. Another thing that I could recommend is if you're interested in dialectical behavioral therapy, kind of the skills-based therapy, there are lots of groups out there. And they're not really process groups. They're more kind of educational groups of learning the DBT skills and then practicing them. I used to work in a clinic that was a DBT clinic, and saw a lot of people's anxiety decrease, depression decrease, just kind of get more stable. They're able to kind of get to know tools to keep them in that window of tolerance.
Great. And can you explain the difference between a process group and maybe an affect group or an educational?
Yeah, so a process group would be processing emotions, processing maybe there's a topic, maybe it's an anxiety group, or maybe it's a trauma group, and you're kind of processing your emotions, what's going on in your life. So it's kind of more therapeutic. And then the educational, the psychoeducation groups are more educational. You're learning about, say, for instance, distress tolerance skills, and then you're spending the week practicing them.
Great, very helpful. And there are also social skills groups, which sort of, it's a little tangential, but It's becoming more popular, I think, for adults as well. That helps with people with social anxiety to have a structure for rebuilding, connecting with people.
Oh, that's fabulous.
Yeah,
Yeah.
think of it more as for autism, but I have more and more patients who are doing it for anxiety, who have social anxiety as well.
Oh, great. Good to know.
Are there other questions today? I feel like this was such a great talk. We're really lucky to have you, and you laid it out just very clearly. I posted the your contact information, and you have it listed here, but the email is therapy@dempseycounseling.com. And you can also contact your provider here to get Diane's information. And again, I will be posting this on our blog page. Thank you so much, Diane, for joining us today.
Thank you so much for the opportunity. I'm really happy to be with you today.
Thank you.